Okay, thank you. So I thought I would do this month's on bariatric surgery and the use of oral anticoagulants. The literature is pretty sparse, but in the last couple of years, there's been some new papers that have come out about it. So just in terms of objectives, a review of bariatric surgery, the types and anticipated alterations of drug pharmacokinetics and dynamics following bariatric surgery, anticipated effects on oral anticoagulants specifically, and then what is currently known about use of warfarin and different DOACs in that setting, followed by current ISTH recommendations. So obesity is one of the most prevalent epidemics in North America, and due to the efficacy of bariatric surgery for weight loss in those with severe obesity, the number of bariatric surgeries that are performed each year has gone up substantially. Over 20,000 patients per year undergo some form of bariatric surgery in the US, with an estimated greater than 16,000 new patients each year suffering a VTE episode in their lifetime, requiring anticoagulation, as well as atrial fibrillation, which is quite common in the population and occurring in around 74,000 patients per year, 3/4 of which require therapeutic anticoagulation. It's an effective procedure with an anticipated 50 to 75% reduction in estimated excess body weight, primarily occurring in the first 1 to 2 years after surgery. So overall, the relevance of clarifying the best antithrombotic management for those reasons is becoming quite significant. In terms of the types of bariatric surgeries, there's quite a few. There's adjustable gastric banding, sleeve gastrectomy, Roux-en-Y gastric bypass, and then very much more rarely used sleeve gastrectomy with biliopancreatic diversion and duodenal switch. So when we're looking at adjustable gastric banding specifically, it was previously the most widely used technique, but has fallen out of favor more recently. Consists of a band around the proximal portion of the stomach that can be adjusted in its size and results in a restrictive type of anatomy that leads to reduced food intake and ultimately weight loss. Adjustable gastric banding is primarily or only a restrictive procedure and doesn't alter food absorption or the size of the gastric or intestinal tract itself. Sleeve gastrectomy consists of restriction of the greater section of the greater curvature of the stomach, resulting in irreversible restriction. That is also associated with hormonal alterations, but leads to fewer deficiencies that are seen in more primarily malabsorptive procedures like gastric bypass. Gastric bypass involves the creation of a small pouch, 20 to 30 milliliter pouch, of the stomach by stapling the upper part of the stomach, followed by restoration of the digestive continuity by creating a jejunal Roux-en-Y limb that then is anastomosed to the jejunum. And that leads to both a restrictive anatomy as well as a malabsorptive anatomy because of short-circuiting of the gastrointestinal tract. And then there's also hormonal changes, which altogether play a role in weight loss. Biliopancreatic diversion and duodenal switch is very complex. For the most part, it does have a larger gastric pouch, but there's a greater degree of disruption in the actual intestinal tract itself and results in an even greater amount of malabsorption in comparison to the others. There are several components of drug pharmacokinetics in general that are altered after bariatric surgery. First, absorption is affected due to changes in gastric pH, which result in changes in absorption of drugs that are primarily absorbed in the stomach. And it can result in a decreased time to maximum concentration of drugs and decreased portion of the upper intestinal tract. Volume distribution of given drugs is also affected. That largely depends on the lipid solubility and other properties of a given drug, but overall is felt to be implicated in terms of how well drugs are being absorbed. There's also an effect with the decreased cardiac output for a variety of reasons, but whether or not that's relevant for all drugs is a little bit unclear. Metabolism is also affected. The reason for this is not super clear. It's been speculated that due to decreased liver size and fatty infiltration, there's greater efficacy of metabolism of given drugs. There is also the decreased first pass metabolism of certain drugs, depending on the type of bariatric surgery that's done. And then whether or not there's an effect on excretion is primarily just relevant in the immediate postoperative period with changes in fluid intake and whatnot that result in a short period of alterations in renal function. The effect of oral anticoagulants specifically is not super clear, but when we're looking at how each of these drugs are absorbed and their bioavailability, some postulations can be made about how bariatric surgery would affect that. When we're looking at warfarin specifically, it's not quite known exactly where it's absorbed, felt to be probably in the stomach and the small intestine. It does have like 100% bioavailability, and it's not affected, the food absorption is not affected by food, but of course other things of a part of warfarin are affected by food intake. When we're looking at rivaroxaban, it can have very good bioavailability, but is dependent on food absorption. The role of food absorption is really isolated to the 15 milligram and 20 milligram rivaroxaban. It's less important for the prophylactic dose. And rivaroxaban is primarily absorbed in the stomach with some proximal intestine absorption as well. The effects or the absorption of rivaroxaban has also been found to be significantly reduced if it's passed into the small intestine early. And so a lot of the absorption is happening in the stomach, which is relevant for bariatric surgery I'll get to later. And then apixaban's oral bioavailability is less. It's primarily absorbed in the proximal intestine. There is some stomach absorption, but it's felt to be more of a minor effect. And then there's no significant effect on food or with food on the absorption of it. Dabigatran and edoxaban is a little bit less detailed, but felt to be primarily, again, the proximal intestine. And there are some changes in the pharmacokinetics dependent on food absorption, but doesn't really result in an overall clinical, any clinical implications. Briefly on warfarin, there's not a whole lot of studies. It's been sort of the go-to management in severe obesity as well as in the post-bariatric group, just because of the ability to monitor and whatnot. This was a systematic review that looked at prior observational studies with warfarin in the post-bariatric surgery population. It included 160 patients. 44% were male, and all were classified as severe obesity with a BMI greater than 40. Primarily, the primary indication for anticoagulation amongst the studies was atrial fibrillation, followed by a prior history of VTE. And overall, they found a pretty significant amount of bleeding events, around 11%, most of which occurred within the first 30 days, and all of them were associated with gastric bypass specifically. When looking at the warfarin dosing over time, it was found that there's about a 25% reduction in overall warfarin dose required to maintain a given INR. Specifically in the first 90 days after up to a year, that kind of normalizes and is overall slightly less. And that's just shown in the graphic there with an overall reduction based on the change from their baseline dose after bariatric surgery. But it does overall normalize years out. The mechanisms for this, again, are very unclear. In that first post-operative period, there's reduced oral intake, potentially alterations in vitamin K intake, and effects of absorption. But it's not too clear. The baseline recommendation with warfarin post-operatively is that the dose is preemptively reduced, with more frequent monitoring in that period. Given the lack of predictability of warfarin together with its significantly elevated bleed risk, there's obviously been growing interest in DOAC use in that population. But a lot of the data that we have from DOACs is primarily observational, and prior studies did not, prior DOAC studies did not include this population, so it's hard to extrapolate to them. Bariatric surgery is anticipated, as I said, to alter the pharmacokinetics of DOACs in several ways, primarily due to alterations of the anatomy and effects on absorption. Given the primary location of where apixaban is absorbed, it's not felt to really be affected by the more restrictive types of surgery, but there's the possibility of reduced drug levels and efficacy in ones that are primarily malabsorptive, like gastric bypass. Whereas the remaining DOACs, they're given that a lot of their absorption's happening in the stomach and the proximal intestine, it's anticipated that they're probably affected, but for some time it was not quite known. This was one of the earlier studies that was done looking at DOACs in this population. It was a cross-sectional matched control study that drew DOAC blood levels in those that underwent a prior history of bariatric surgery. They did control them with age, sex, and BMI matched controls of healthy individuals that never underwent bariatric surgery. And they included a total of 36 patients, majority of which underwent sleeve gastrectomy. 9 patients were on apixaban, 7 on rivaroxaban, and only 2 on dabigatran. And overall, the median time since their bariatric surgery itself was 4.9 years. There was, comparing the control to the bariatric surgery group, there was no patients in the control groups that had drug levels below the expected ranges that were taken from the phase 3 trials previously. And there was 5 or nearly 30% of patients in the post-bariatric group that had drug levels below the expected range. Primarily, those were rivaroxaban specifically. 80% of patients that had drug levels that were lower than expected had a prior history of sleeve gastrectomy, and only 1 had Roux-en-Y gastric bypass. And all of them, again, were on rivaroxaban. There was no significant differences between the control groups and apixaban and dabigatran, but the overall size of the study was obviously quite small. And there was limited insight in terms of the clinical implication of those drug levels and whether they were resulted in any clinical outcomes of interest. In 2017, this was a single-center, open-label, non-randomized trial that was looking at prophylactic doses of rivaroxaban. They only included 12 patients, 6 with a prior history of bypass and 1 with a sleeve gastrectomy. And they essentially enrolled patients, and the patients received a single dose of rivaroxaban 10 on day 1 preoperatively, as well as 3 days postoperatively. And then they had venous sampling occurring incrementally over the next 24 hours since their dose to determine the PK and PD of rivaroxaban 10 milligrams only. Their primary outcome was looking at pharmacokinetic parameters, peak plasma concentration, terminal half-life, and area under the curve, with a secondary endpoint for safety with mortality and clinically evident DVT, PE, and bleeding events. These charts are a bit above my head in terms of pharmacokinetics and dynamics. But when they compared those rivaroxaban 10 and separated them based on the type of surgery after a single application of rivaroxaban 10, the curves were overall quite similar between pre and post-op. There was a lower maximum concentration seen in the bypass group versus a higher postoperative concentration in the sleeve gastrectomy group, but overall the differences were pretty insignificant. And from this small study, they concluded that it was pretty comparable between the pre and post-op setting for rivaroxaban 10 specifically, and it was not, and bariatric surgery, whether restrictive or malabsorptive, didn't significantly change that. Obviously limited to this being a prophylactic dose, together with the fact that we know that the prophylactic dose is less affected by food intake and whatnot. So a little bit difficult to extrapolate from that. They also looked at pharmacodynamic effects following this, and again, there was no significant difference. There was a more, looking at the thrombin and antithrombin complex, there was a greater drop in thrombin-antithrombin complex within 1 hour post-operatively after 1 hour following their dose in the post-operative setting, but these patients had received low molecular weight heparin DVT prophylaxis per regular hospital protocol, so it was postulated that that was likely the reason for that, but overall no significant change. And again, just another pharmacodynamic portion of this. Looking at prothrombin activation fragments, they significantly dropped within 12 hours after 12 hours after they had received the dose. And again, the levels were significantly lower in the postoperative setting, presumably because they had received low molecular weight heparin. A year after that, they did do an extension trial, so around 6 to 8 months after bariatric surgery, to see if there was any delayed change in these parameters, and overall, there wasn't. They concluded that the changes in anatomy, together with extensive weight loss after bariatric surgery, did not significantly change the parameters of single-dose rivaroxaban 10, regardless of the type of bariatric surgery that they had. Recently, this study did a similar thing, looking at full-dose rivaroxaban. It was a single-center study called the Absorb study that was non-RCT, and it was parallel design. And they were looking at the effects of bariatric surgery following full dose of rivaroxaban, again, with a single dose provided, or single dose given on day 1. They continued that for 8 days and rechecked the parameters after they achieved steady state. Their primary outcomes were looking at plasma concentrations on day 1 as well as at steady state, and then maximum or time to maximum concentration as well as area under the curve, so just PK parameters, with a secondary outcome of clinical events of bleeding or other adverse events. These graphs show the area under the curve in both the gastric bypass, the sleeve gastrectomy in the 2 corners, and then elevated BMI patients who have not undergone bariatric surgery compared to healthy controls with normal BMI and no prior history of surgery. The area under the curve for the surgical groups after the first dose of Riva was overall lower than the mean of the controls. But the differences were quite small. It was 6% lower in gastric bypass and 14% lower in sleeve gastrectomy, and overall not significant. And then when looking at the maximum concentration, it was lower in the gastric bypass group, but again, the differences weren't pronounced once they had achieved steady state. In terms of their secondary outcomes, I didn't put it on this slide, but there was no adverse events or deaths or bleeding or significant bleeding that were noted. There was one major bleeding event in the gastric bypass group, isolated to menorrhagia and resolved afterwards, and otherwise no significant difference in minor bleeding between the groups. So overall, that data suggested that there was, again, no significant effect on the parameters or these parameters with full dose rivaroxaban in malabsorptive or restrictive bariatric surgery. But the clinical relevance of that was a little bit unclear, and the number of adverse events that they had were very small, so couldn't quite draw any conclusions from that. The same thing is previously done with apixaban, again, a small study. They included 28 patients with an average BMI of 49, and they investigated, again, a single dose of apixaban administered to patients undergoing bariatric surgery, specifically sleeve gastrectomy or gastric bypass. And they measured levels in the immediate and post-operative period, as well as up to 12 months. And we're looking at factor Xa activity as well in the 3 to 6 hours after dosing, both immediately and after steady state. And their primary outcome was looking at area under the curve of that, with no significant outcomes looking at safety or anything of the sort. When they looked at the area under the curve, there was an increase in that PK parameter 1 month following bariatric surgery, but that decreased to below perioperative or preoperative levels by 12 months. And that effect was primarily seen in gastric bypass. There was no other significant changes in Cmax or half-life for either of those situations. And then looking at the factor Xa activity, which is the chart on the right, the dark bars are the gastric bypass and the light ones are the sleeve gastrectomy. There was no significant changes between the two. There was, interestingly, a progressive diminishing of the factor X activity from pre-dose to 3 hours over the time period, and that was most pronounced in the sleeve gastrectomy group. The relevance of that is a little bit unclear, and the reason for that is unclear, but that was just the trend that was seen. Overall, they didn't find any significant effect of bariatric surgery on the absorption or the effect on factor Xa inhibition with apixaban. And they speculated that that progressive decline of pre-dose factor Xa, maybe in the setting of reduced fatty liver and increased metabolism, together with a bunch more other speculations were made, but whether or not it was clinically relevant wasn't clear. There was also no significant degrees of supratherapeutic factor Xa, which was reassuring. So in summary, just from the pharmacokinetic perspective, there's been no obvious data suggesting that there is significant variation in apixaban. There's some reassuring evidence for rivaroxaban, that rivaroxaban can be used, but it's really quite conflicting, and the trials are quite small, so not much can be gleaned from them. And there's been very limited pharmacological data on dabigatran or edoxaban in that group. And again, how that translates to clinical outcomes is still unclear. Looking at real-world data of DOAC use in this population has been really limited to, again, small population observational studies. Recently, this was a systematic review that compiled the prior observational studies that have been done. They included 28 studies with a total population of over 3,000. The majority of patients were on apixaban. There was a very large portion of unspecified group, and then next to that was rivaroxaban, with very few using dabigatran or edoxaban. The primary outcome was clinical based, so incidence of ischemic stroke, systemic embolization, TIA, venous embolism, with a secondary outcome looking at DOAC pharmacokinetic data that was not included in all of the studies, so it was pretty sparse. In this systematic review, there was 2 arterial events out of 834 patients, with a combined almost 300 patient years of follow-up. And arterial events had an incident rate of 0.73 per 100 patient years. There was 8 VTE events out of 2,486 patients, with an incidence rate of 3.4 per 100 patient years. And the degree of which those, well, there was a lot of variety in terms of the type of VTE that patients had. And so it was a pretty heterogeneous group. They also looked at bleeding. There were 17 bleeds overall, and bleeds were more common, obviously, in the treatment group rather than to thromboprophylaxis or healthy controls for the studies that had it. But overall, given the low quality of the studies included, it was a very low certainty evidence that was overall concluded from. They did compile the pharmacokinetic data of apixaban, rivaroxaban, and a very small group of dabigatran. And of the patients within the studies that had levels, a number of patients that had levels were quite small, but all of the apixaban patients had drug levels within the target range. Rivaroxaban, 50% of patients were below the range, and a small subset were actually above. And then the dabigatran group was a very small group, but 75% of patients had drug levels below target in that group. From that, they developed an algorithm to determine which anticoagulant to use for patients. They sort of followed in line with the idea that in the immediate postoperative setting to continue low molecular weight heparin, and if a DOAC were to be started, the preference would be for apixaban with levels to be done in the postoperative range or the postoperative period. And if they were in target, to continue, and if they were out of target, then the discussion would be for transitioning to warfarin. In 2022, this was a study that was retrospective. It was cross-sectional, longitudinal. They investigated the anti-10A levels of apixaban and rivaroxaban in patients with severe obesity before and after they underwent gastric bypass specifically. They included 52 patients, the majority of which were on apixaban, and only 12 on rivaroxaban. And there was no significant differences in terms of baseline characteristics. They measured the anti-10A activity both preoperatively and postoperatively, and all of the postoperative measurements that were done were taken at least 2 weeks after surgery. For those that had levels available, this chart shows the anti-10A levels as a function of body weight on the bottom. And preoperative levels were measured in 29 apixaban patients and 12 of the rivaroxaban. In the apixaban group, the levels were predominantly within the therapeutic range, but they tend to teeter off above a weight of 144 kilograms. Whereas for rivaroxaban, there was no significant correlation with weight and anti-10A levels, but a lot of them fell outside of the expected range. Gastric bypass surgery levels were measured in 28 patients who were on apixaban postoperatively and 14 on rivaroxaban. All of the levels for apixaban were within the anticipated target range, while most of the rivaroxaban group were falling outside, primarily subtherapeutic. 64% of them were subtherapeutic, actually. And they did also recheck the levels at 1 year for 20 patients had levels at 1 year done. And of the ones that were within range in the postoperative period at 1 year, they remained within the therapeutic range and did not necessitate any change in therapy. There was a few apixaban patients, 18, that had both pre-op and post-operative levels done. And of those that had those done, there was no significant change in anti-10A levels between those periods. So overall, the conclusions they came to was that with apixaban specifically, anti-10A levels were typically within target range, and there was no significant change pre or post gastric bypass. Whereas, well, also with rivaroxaban, there was the issue with some changes in anti-10A levels based on weight, specifically above 140 kilos. The discrepancy with weight was not seen with rivaroxaban. However, they were patients who had gastric bypass frequently fell in the subtherapeutic anti-10A range. More recently in 2023, this again, observational retrospective study that was primarily looking at thrombotic and bleeding events with a secondary outcome stratifying based on surgery type, as well as time since surgery and DOAC agents. They included 191 patients with a pretty decent amount of follow-up. Most patients were female, most were on rivaroxaban, and most were post-gastric bypass. And the primary indication for 52% was atrial fibrillation, with a small portion on lower intensity prophylactic DOACs. In their population, clotting events occurred in 5.8% of those that were receiving DOAC. And the frequency of which those that were on rivaroxaban were having clotting events was numerically higher, but once they were controlled for confounders, there was no significant association between the rivaroxaban specifically and clotting events or bariatric surgery type and clotting events. When looking at bleeding events, that occurred in 22% of patients on DOAC, with a calculated incidence rate of 17 per 100 patient years. 36% of those bleeds were major bleeds, and 33% of the major bleeds were GI origin. And again, numerically, there was more bleeding events that occurred in the rivaroxaban group, which made up the majority of DOAC agent in this population. But once they adjusted for confounders, there was an increased risk of bleeding associated with those that had active malignancy, were on rivaroxaban in comparison to apixaban, or had a history of renal disease. And 95% of bleeding events occurred in those that were on therapeutic intensity treatment. Overall, they concluded that while clotting events were rare, suggesting potentially adequate absorption, bleeding events were quite common, occurring in 22% and associated with rivaroxaban use specifically, history of active malignancy or renal disease. They postulated several potential reasons for that, including friable mucosa, bypassing of first-pass metabolism, which may lead to increased absorption. But overall, it was unclear. But that notion of rivaroxaban being associated with more bleeding events, specifically GI, is comparable to what we know at baseline from other studies. Last year, this again was a retrospective study that looked at DOAC levels following any type of proximal GI surgery. They compared on-therapy ranges derived from prior published data to determine whether or not these patients were in the ideal range. And their main outcome was looking at rates of VTE, arterial thrombosis, major bleeding, or all-cause mortality. 61 patients were included, with a total of 65 levels drawn altogether. Majority of patients were on apixaban, 41 were on apixaban, and 20 on rivaroxaban. The primary indication for anticoagulation in that population was VTE. 75% of patients were on anticoagulation for that reason. And of those that were in the bariatric surgery group specifically, there was the majority were gastric bypass. Over 70% of DOAC levels were within the pre-specified target range, and 85% of those were patients who were on apixaban at baseline, and only 50% were on rivaroxaban. There was no significant difference in the target range based on surgery type that patients underwent. They found no thrombotic or bleeding events in the post-bariatric surgery group, and all of the bleeding and thrombotic events were isolated to post-cancer resection, likely obviously explained by several confounding factors. But overall, 25% of patients with a history of proximal GI surgery had lower than expected drug levels, primarily those that were on rivaroxaban. But obviously it's limited by, there was no specification of when these drug levels were taken, if they were in steady state. There was no known baseline done prior to surgery, and the group overall was quite heterogeneous. Last year as well, this was a retrospective study done, again looking at steady state of DOAC levels, and they included a total of 57 patients with a total of 89 levels drawn and a mean weight of 140 kilos. Majority of patients underwent sleeve gastrectomy, followed by gastric bypass, and only one of the diversion and switch surgical type. Their primary outcome was looking at mean drug levels and the proportion of which peak drug levels were within the expected range. For patients who received DOAC in the postoperative period, they did separate their findings based on DOAC agent type. And then their secondary outcomes were more clinical based, looking at the 30-day incidence of thrombosis, major bleeding, or mortality. And they did look further out 6 months post-op for peak levels at that point as well. Results, looking at rivaroxaban at the top specifically, 7 out of 29 patients had drug levels below the expected range, the majority of which were those with a history of gastric bypass. And then dabigatran, none of them were within the expected range, regardless of the type of surgery. While apixaban, there was one patient out of 21 that had drug levels that were lower than expected, but they actually repeated their level, and it might have been a lab error, but on repeat, the level was actually within range. So there was technically no apixaban that was below the range. And then with edoxaban, there was no one that had levels below the range. Those that were initially within range did have repeats done about 6.5 months later postoperatively. And most of those were sleeve gastrectomy, 13 were sleeve gastrectomy, and 2 were gastric bypass. And if they were within range in that first pre-operative or post-operative period, they were all within range 6 months later. In terms of their clinical outcomes, within 30 days post-surgery, there was one VTE event in the context of rivaroxaban being held, and they developed a post-operative pulmonary embolism on post-op day 2. There was no major bleeds and no deaths in their population. So they concluded that only a minority of patients taking a factor Xa inhibitor after sleeve gastrectomy specifically had drug levels below the expected range. But those who underwent more malabsorptive surgeries like gastric bypass, or they were taking dabigatran, rivaroxaban in the setting of malabsorptive surgery, were at a higher risk of subtherapeutic levels. The current recommendations from ISTH from 2021 recommends that DOACs not be used in the immediate postoperative period, and instead they continue with low molecular weight heparin for the first 4 weeks. And if the decision is to transition to an oral anticoagulant, and if you were using DOACs, that not be considered for at least 4 weeks. And if it's done, DOAC trough levels be checked for adequate absorption and bioavailability, but they don't specify any specific time frame for that. And if they are subtherapeutic, then that would require initiation of transitioning to warfarin at that point. So in summary, when it comes to warfarin, the need for dose reduction is expected in the early postoperative period, but obviously it harbors a high incidence of bleeding, around 11%, primarily in those with a history of gastric bypass. The data that we have to support or not support DOAC use in this patient population is limited to small, low-quality evidence. There's conflicting evidence in terms of the use of rivaroxabans. Some of the more recent pharmacokinetic data suggests that it should be okay, but a lot of conflicting evidence for that. There's been relatively consistent evidence for apixaban that the concentrations are not significantly altered, and there's not much data, if at all, on dabigatran and edoxaban. Whether or not the pharmacokinetic data translates to any significant clinical outcomes remains pretty unknown. All of these studies were quite small. Their clinical outcomes were quite rare. So it's hard to draw any definitive conclusion from that. But the overall recommendation is, for a variety of reasons in the immediate postoperative period, to use low molecular weight heparin, both given the changes in intestinal transit time, together with increased bleeding risk and unpredictability, with consideration of transitioning to DOAC after 4 weeks, with checking anti-10A levels once in steady state to confirm adequate absorption. That is what I have.